know exactly where it's located. Take an autofluorescent image, you know exactly where it's located. And I give you an example. You see color? Blood here, can be older or not, but you see in autofluorescent. Right, it's subretinal. And that is sub-RP. That is an old blood, fluoresce, and also we will see that there is another information about the old blood with another fluorescence characteristic, another old blood. Fibrin, that mask. Then ardexodate. Ardexodate are in the neurosensory retina. So you have such a things. Then you have myelinated fibers or epiretinal membrane. Myelinated fibers look like that, interfere with the fluorescence, not the epiretinal membrane. You see in a blue light, it's because blue light is reflected by the inner layer, you actually see very well here. You don't see anything in autofluorescence. Reflection image, fluorescent image. Then you have the mottling pigment, and here can be something different. For example, retinitis pigmentosa is black. Juxtafoveal telangiectasia is black. In age-related macular degeneration, this is a serious retinal pigment detachment. It's white. It's fluorescent. And you know why? Because all this pigment that you see here, and also in color or in infrared, that are more reflective, it's not autofluorescent, it's white because it's melanolipophosphatase. So we saw that it's fluorescent. Then we have choroidal nevus, but usually choroidal nevus is behind, and choroidal melanoma, but could be behind the RP, but it's a little bit different. Choroidal nevus, very well visible in infrared, not visible in red free, not visible in autofluorescence. Choroidal melanoma, one of the yellowish material that you see over a choroidal melanoma is lipophosphatase. And it's a very well-known bad sign of a nevus. If you see lipophosphatase over it, it's a choroidal melanoma. And you see how fluorescent is comparing with the nevus. How you acquire a autofluorescent image with the old HRA, just putting the fluorescent filter, and the same for HRA2. With HRA2, you have right now a new software. Well, it's not so new, but so pressing that button, you actually can get a live mean of images like that. Usually you are able to take a movie and then to do a mean of all the images of 9, 12 images of one short movie with this is called art software. Yes, acquisition in real time is actually averaging, and you have a mean image, and you decide to grab that image when it's quite clear and sharp. Now, when autofluorescence is useful, here are some examples, and we will go through with you to some, retinal dystrophies. Now I go on some information that we acquired with a different instrument that was able to, it was a spectral photometer that was able to measure lipofuscin in live patients. This is a normal distribution of lipofuscin, as I said. The more you grow, the more you glow. And here are standard patients. And you see that a young subject, like is 13 years old, is equal to a 51-year-old normal subject in the content of lipofuscin. And I will show you the images of some cases, and you will understand that also through an image you can really have an idea. So this is started with that 13-year-old subject. You see some flecks here, but also a background that is quite visible. You remember what we said yesterday about that young subject with an high fluorescent background. And now we want to compare with a normal subject of 13-year-old, the same age. Here is the fluorescence. You see it's almost invisible. Now, if we now take a 51-year-old subject, normal subject, with the fluorescence, you see that it's equal to a young person. So in fact, one of the theory of the Stargardt disease is that the accumulation of lipofuscin is faster and reach a level of dangerous level where the RP cells start to die. It's one of the theories that the first problem starts from the photoreceptor that are not very well, how can I say, are not be digested, and so the accumulation of lipofuscin start to be very fast. So just to give you an idea here, you see that this fluorescent background, don't look at the flecks, but just fluorescent background is similar to the one of 51, and the 13-year-old, same age, normal subject is much, much less. So just looking at the background, you can have an idea if you have some RP dysfunction or not. And this is another Stargardt patient where you see all the increased fluorescence here that seems to announce the new area of atrophy. And just to see this patient, you see that where fluorescence increased, you have an increase of atrophy. You see here, we don't know exactly how long does it take to have an increased autofluorescence before the atrophy appear, but for sure it's a sign. And this is also a sign, okay, this is a Best disease in 8-year-old child, and you see how all the steps of the Best disease are visible here in a short time, and you can actually see details of the single cells that has more lipofuscin and not others. Cone dystrophy in autofluorescence is always like that. If you see a ring here and a decrease in autofluorescence in the center, it's a cone dystrophy. So just having this image, you're almost sure that it's a cone dystrophy. retinitis pigmentosa. You don't have an increase, it's not clear if you have an increase of fluorescence here or it's just because you match some hypofluorescence with the hyperfluorescence, or normal fluorescence appears with hyperfluorescence. Because remember that in any image, fluorescing, ICG, or autofluorescent, you are always comparing one area to another. And it's difficult to say which is the normal fluorescence, because sometimes you actually add an area that is less fluorescence, and the one that is normal looks like higher, but it's the other way around. So things always that can be not as your eye gives the first impression, but think that it can be the other way around. You know, it's hypofluorescent and not hyperfluorescent. In age-related macular degeneration, it's for sure used for the dry AMD. This is a classification that we did with our colleagues from Germany and from England in dividing drusen on autofluorescent image, and not just hard and soft, or hypofluorescent, hyperfluorescent based on fluorescing. This was done at Frankfurt Airport, so it was a kind of a nice image and nice meeting. And here, the first drawing of when we try to classify. When you have atrophy, and we already seen this image, there is a decrease in autofluorescence. But as we say for Stargardt, and as Frank Holz from Bonn suggested, when you have an increased fluorescence around an area of atrophy, you can actually expect that the atrophy will increase in that area. Like, for example, here you see that was done in this way. We already seen the RP mottling pigment that is fluoresce more, and there is a really practical way of using autofluorescent with a fluorescein and ICG with you see a membrane here and a RP detachment here, an autofluorescent image here. There is no particular changes, but what do you think? What happens here? A rip of the RP cells. So, RP detachment. So, it's quite visible here in fluorescein, in ICG, but look in autofluorescent, and here is a fresh one. When you have one that already happened, it's difficult to understand if it's a rip or not. Take an autofluorescent image, and if you have such a thing with a sharp border here, it's always a rip of a retinal pigment. And what about this case? You see, red-free, fluorescein early, late, ICG early and late. It was referred to us for a photodynamic therapy some years ago. What do you think is the diagnosis here? Do you think this is leakage? I will show you some image that you take before an injection with autofluorescence. And you see that this area is already autofluorescence. There are some spots here that I will try to explain later, but this is not fluorescent accumulation. It's just in the late phases you take the autofluorescent image. So it's actually an accumulation of hypophysin. This is a pseudovitelliform lesion. It's not any CMV at all. And all these little dots are just RP cells that are migrating in the neurosensory retina. There is a nice specimen by Gregory Agman that show this movement of cells full of lipofuscin, and now with the new spectral domain OCT that is coupled with the HRA, we can actually cut here and see cells in the neurosensory retina. I have an example, and if you want, I will show you later. This is another case, referred to us, two other cases, referred to us for photodynamic therapy. Early and late frames, early and late frames. Remember, a fluorescent angiography is a dynamic exam. It's not just one single frame. Based on these two images, you can think these are leakage, and there is for sure a CMV. But if you take an image early, you see that there is an early increase of fluorescence here, and a blockage here. Now, remember that before doing an injection, it's better to take an autofluorescent image, and here are the two autofluorescent. You see that this hyperfluorescent here corresponds to a dark area here. What does it mean? It means that there is no RPE cells. It means that this is a window defect. It means that this is an atrophy. Then we have an increase of fluorescence in the late phases, but it's not leakage. It's already visible in the early stages. And this is just an accumulation of lipofuscin. This is a pseudo-epithelial lesion, no CMV, no treatment at all. The same here. You see an increase of autofluorescence, and actually gives the information that this late image is just showing lipofuscin material. And remember, because it's a dynamic exam, at the beginning, if you have lipofuscin, it's masking. It's not. If it was a CMV, it should be leakage immediately. But you don't need fluorescing if you do an autofluorescent image before. You have all the information that you want. Why I have to do an invasive test if I know already that there is an atrophy and there is some lipofuscin there. And this, I think, is the best example of what autofluorescent can give you. This is a CMV, for sure, there is blood. In dynamic ICG, I see also the vessel that is actually part here and part over here. But look at the autofluorescent. Let's try to read together. So, what is this? Great. And what is that? An increased fluorescence. It means that probably the atrophy will increase in that area. Then I have here something, the blood, that is over the RPE. And here, there is fluid up to here, because they interfere with the fluorescence that comes from the RPE. I don't know where is the lesion, but I have more information, for example, the atrophy, that I couldn't get from these images clearly. And we didn't inject anything, we did before. Macro hole. This is a typical image of a macro hole in autofluorescence. And now there is a nice paper from one of my colleagues that works in my hospital on just published on BJO about how the autofluorescent is important to couple with the OCT for judgment of surgery in the macro hole patients. And what do you think? Is the autofluorescent and the red-free image of another case. Do you think it's a macro hole? There is an increased fluorescence here. Just to remind you, I don't have here, even yes, probably it's now, yes. This is how should appear if you have a full thickness macro hole. This patient, in fact, still has some tissue here, and you see that it's not round shape, it's not characterized by an increased homogeneous autofluorescence. And why we have, I forgot to tell you why we have autofluorescence increase in macro hole, but I think you can say.
For the
what is missing here?
We don't have a retina.
And so we don't have in the macro, in the fovea area,
Nothing that
macro pigment. So we see directly the fluorescence that comes from the RP, that can, reduced by some tissue here and not reduced by any tissue here.
So that is an earlier stage?
Yes, you see, it's still some tissue, but that was coming from some cyst that was broken. And by the way, this patient has a 20/20 visual acuity. But you see, you can actually differentiate the macro hole. And you can actually see if surgery did well, because there is a strong correlation between the disappearance of increased autofluorescence in patients that did well for visual acuity during the time, with people that has still some fluorescence in the center. And this is really a unique case. What is strange in these two images? I will try to show you. You see this line? You see this line? There is actually another line here, and here, and here. What is this line?
Correct.
Is the location of vessel before macropacker. Macropacker move the vessel out of their position, and there is an increase of fluorescence here. Now, it's not clear why. We try to give some explanation with Janet Sparrow and François Delory, and probably is one of the reasons is because if you wait some times, it means some years can disappear.
That is the place where
The vessels were before, and probably because if are covered by the vessel, the RPE cells increase lipofuscin, but the light can bleach lipofuscin. This was one idea. The second idea, but it's a little bit more difficult to demonstrate, is that in that area there are no photoreceptors. And so it's like a window defect of the problem is that now we have the spectralis, and we can actually look really at that point because we can overlap the line of the OCT compared with the side-by-side image in real time. The problem is that it's not easy to find this type of patients, and since we have spectralis, we have no one patient with this shadowing. The other test that we are trying to do is the dark adapted and light adapted, because if it just due to the photopigment around, it will disappear if I bleach all the photopigment. But the other idea was, well, if it's true that these are the vessels where they were before, why we should see in macro translocation patient. And here the 360 translocate lines, you see that the lines of the vessel were before. And then there are so many other use of the autofluorescent to look at the cystoid macroedema, like in van gas, or in